Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hello, everyone. Welcome to the Chest Journal podcast. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota. And today it is my super pleasure and privilege to welcome Dr. Hemang Yadav, also from the Mayo Clinic in Rochester, Minnesota. We're going to be talking about his paper in this month's journal on intercession variability in single breath diffusing capacity of carbon monoxide. Dr. Yadav, welcome.
Thank you so much, and I'll hopefully make this a little bit more interesting than that title sounds, so we'll make it more fun.
Oh, we're going to make it super fun. And to start, tell our listeners what in your day-to-day job inspired you to ask this research question.
Yeah, so I work in a center that does a huge PF volume daily. So we do about 100 PFTs a day. Most of them involve diffusing capacity. And really the issues stem from the fact that, we have, really rigorous technical standards on how to perform DLCO, quality control, equipment calibration, etc. And we also have really well-developed normative equations for, how far somebody is from, what's expected of them based on age, height, and sex. But we really struggle to know, how to interpret these longitudinally. And I think that, anyone who uses DLCO, which, after spirometry is probably the most useful and most commonly performed PF test we do, knows that, you see a patient in your ILD practice, for example, their DLCO was 65% predicted last time, is 58% predicted now over 6 months. Spirometry has been stable. Is this, disease progression? Does this warrant treatment escalation? Or is it just measurement noise? And those answers, they do change patient management, but really there's a big gap in understanding, whether this is true change versus noise.
Oh, I love that. And I agree with you. The LCO is so important. And we use so much in our clinical practice in pulmonary. You're so right. So to answer that question, share with our listeners, what were the methods you and your team used?
Absolutely. So, our hypothesis going into this was that that intercession variability, and what I mean by that is, between two different days we do DLCO, what that variability is probably exceeds common thresholds that we use. And, that's because DLCO really integrates alveolar volume inflation, breath hold time, inspiratory gas mixing, performance, equipment calibration, so many different factors, hemoglobin. And so there's so much inherent variability there. Our hypothesis was that it would be higher than what is conventionally thought to be normal. And those conventions, there's different metrics that are used. So some people use absolute change in units. In the US, we use mils per min per millimeter of mercury, and then they use SI units in Europe. But essentially, in our practice, in our unit, we use an absolute cutoff of 3.2 to signify significant change. But that's really not a well data-driven metric. So the other metrics that are used are percent predicted change and relative percentage change. And different small studies have described each of these in the past. So we want to look at those different metrics and see kind of how that would vary for DLCO. And our other hypothesis here is that DLCO variability will vary with the baseline DLCO magnitude. And what I mean by that is that, if the measured quantity increases, your absolute measurement error will probably increase proportionally, even though the relative error may remain constant. So if someone's expected DLCO is 35, a change of 3 is easy to achieve. If someone's last measured DLCO is 10, that absolute change of 3 is going to be really hard to achieve.
Yeah.
And so we wanted to try and explore that in more of a data-driven kind of way. And the last part was to see really, what factors would affect variability day to day. Would it be, hemoglobin, the fact they have restriction or obstruction, time between tests, etc. So we looked at that as well. And so to do that, we used a database of routinely ordered clinical tests. So this is at 3 different sites in our health system, Rochester, Eau Claire, and Florida. And it's from 2016 to 2022. We have over 100,000 tests in that database, of which about 60,000 have DLCO testing.
Okay.
And what we wanted to do first was to say, okay, so, how do we ensure that their lung function has remained stable? And so to do that, we had a definition of spirometric stability, which was that the 2 tests had to have both FEV1 and FVC differ by less than 5%. So in terms of absolute values, for a typical individual, this would be around 100 to 150 milliliter variation between FVC values. So it is smaller than the accepted day-to-day variability for each of these metrics, but it was pretty strict. And the goal is, like I said, to make sure that lung function from a spirometry standpoint appeared to be stable.
Mm-hmm.
Our second requirement was that you had to have a hemoglobin. We know DLCO is affected by hemoglobin, so we can't use uncorrected or unadjusted hemoglobin in this context. So we had to have a hemoglobin within 3 weeks. And that just balances clinical reality. I mean, we don't draw hemoglobin every time we do a PFT with biological relevance. The hemoglobin, typically changes slowly. And obviously people can have acute changes, but they're unlikely. So hemoglobin requirement and spirometric stability were required. If people had, say, 5 or 6 or 10 spirometry tests, we used the one that had the shortest interval between tests for comparison, just to minimize whatever biological drift might be there. And like I mentioned, we use 3 variability metrics: absolute change in milliliters per minute per millimeter of mercury, change in percent predicted, and relative percentage change. So each of these 3 metrics we looked at. And the first thing we wanted to do as well was to look at how those metrics varied as DLCO changed over time. And so that's why we did that assessment, which I'll go into a little bit, during our results. So then we talked about kind of, what different thresholds should we use? And, I think that there were a few reasons for choosing a graded threshold and a few reasons for choosing a binary threshold. So a graded threshold just essentially means that, we create, boundaries that have an uncertainty zone in the middle. And that's really for a couple of reasons. One is that the distribution of changes is right skewed. It's not normal. And so what that means is most patients have small changes, but there's a long tail of larger changes. And so in that context, a percentile system is probably more robust than a parametric approach where we look at standard deviations. And then we looked at a 3-tier system because, binary classifications typically force clinicians to yes/no decisions that don't really reflect measurement uncertainty. And so the 3-tier system was designed to say that, listen, if we have high confidence the patient is stable, we have uncertainty zone requiring clinical integration, and then we have high confidence of real change. And so we use a percentile-based approach to define these three grades, stable being below the 85th percentile, possible change being between the 85th and 95th percentile, and definite change being above the 95th percentile for each of the three metrics: absolute change in percent predicted, and relative percentage change.
Okay. Well,
I think that reflects clinical reality. I think we don't view these changes in isolation, and so that uncertainty zone reflects what biological reality is. The binary classification system we also looked at, just because sometimes you need binary decisions. Sometimes it's too complicated to have graded systems. Sometimes, for example, clinical trial endpoints and enrollment, you want to have kind of a binary decision threshold. And so for that, we set a limit of 90th percentile.
Okay.
And the last thing that we did was to look at that issue of measurement variability increasing as the DLCO magnitude increased. And that's what's called a hybrid rule. So basically here we said that, if the baseline DLCO is less than 50% predicted, we use one threshold. And if baseline DLCO is greater than 50% predicted, we use a different threshold. Mm-hmm. And the goal there was, is this going to be a better performing metric across the spectrum of DLCO that we see in clinical practice? Or is the graded system better, or a simple binary system better? And, the hypothesis there really is that the hybrid approach would show more consistent classification across the range of DLCO. Mm-hmm. The 50% predicted cut point was arbitrary, but it felt clinically meaningful since it correlated with moderate impairment. It approximated the inflection point in our analysis of how measurement variability increases with DLCO. And it was kind of straightforward and memorable. So, it was kind of an easy thing to remember. So if this were to be used in practice, it would at least be something that is straightforward. So that's the different grading systems that we looked at. And we also looked at combined approaches, using and logic and or logic to say, you need absolute change and percent predicted change, etc. So we explored all of those different options here to kind of outline what variability looks like.
Oh, I love that. And I love the way you guys looked into it is also very helpful for our listeners when they want to use your results for their clinical practice, which is a perfect segue for you to share with our listeners. What did you find?
No, absolutely. And the findings are quite they're quite a range of findings that do fit reasonably well with what we hypothesized. So we saw that the 90th percentile values in change in between sessions mm-hmm. was 3.5 milliliters per minute per millimeter of mercury for absolute change, 15% predicted, and a 21% relative change. So all those are quite a bit higher than what we would routinely expect. So say we used the conventional thresholds of 3 milliliters per minute of mercury for absolute threshold, then we'll find that 14% of patients are exceeding that threshold, even if they have stable spirometry. If we use a 10% relative change as a threshold, 38% of patients will have a significant change, between tests, which seems way too high. If you have stable spirometry, you would not expect 4 in 10 patients to have a clinically meaningful change in DLCO. So those changes were larger than than is conventionally believed.
Okay. And for our listeners, if you have the manuscript in front of you, it is figure 1.
Okay. That's correct. Absolutely. And then the second finding was that variability does increase as we expected with DLCO magnitude. This is, in the paper, but the figures for this are more in the supplement.
Yeah.
And, to do this, we look at what's called a Spearman correlation coefficient between absolute difference and mean DLCO. And what it means biologically is just absolute measurement variability will increase as DLCO increases. So a single cutoff of absolute change will struggle to accurately quantify change across the spectrum of DLCO changes. And so if you're visualizing this, this is in the supplement in Figure 2. So if you look at that, how that will work, if a patient who has a low baseline DLCO of say 10 milliliters per minute per or millimeter of mercury, or 40% predicted, the absolute changes tend to be smaller. Mean variability is around 2. And that same 2 absolute change corresponds to about 20% relative change. And so the relative thresholds will be really sensitive. The absolute thresholds might be really specific in this context.
I love that.
All right. So the next thing I want to talk about a little bit is our findings in Table 2, which is trying to look at, what influences variability. So if you have, patients and their DLCO differs by X amount, what known factors that we can account for affect those things? And so what we found is the strongest predictor is your baseline DLCO, again, fitting with this measurement size hypothesis we've had. So for every for every 1 unit of higher baseline DLCO, expect about 0.07 more variability. So that kind of quantifies that change. Even accounting for that, men will have more variability than women. And then time between tests did affect it, but to a very small degree. So it's essentially biological drift over long monitoring intervals only contributes a very small factor. Hemoglobin also affected it. So lower hemoglobin was associated with more variability. And what that means is that the current hemoglobin adjustment equations are probably undercorrecting for anemia in DLCO. The other factors that were responsible from Table 2 here are that possible restrictions, so reduced FVC will have more variability, and that might just be a reflection of heterogeneous gas exchange. But taking it all together, the adjusted R squared here is 0.114. So what that means is only 11% of the variance is explained by these factors. So almost 90% of variability is unexplained. And so those are technical factors, patient factors, cardiac output, when did they last exercise, temperature, did they cough in between, the breath hold test. And so that large unexplained variance essentially reinforces why these generous thresholds are needed and why clinical context, really has to be applied when contextualizing these factors. And, we did a lot of kind of nerdy stats in here that looked into how reproducible all this is. And essentially, when you do things like what's called bootstrapping to try and reproduce these, it tends to be pretty reproducible.
Yeah. We like nerdy stats here in the spot.
I unfortunately, I also enjoy nerdy stats a bit too much. Yeah.
We welcome them. And what would it be? Some of the take home points that you would like the clinicians, like when they receive a result from a DLCO, to have in mind based on what you guys found.
Absolutely. So maybe it's a good time to talk a little bit about the graded system, the times where it's good and when it's not, and the hybrid system. And so
we're talking about Table 3.
That's right. Exactly right. And so the conceptual framework here is just to maybe embrace the fact that there is uncertainty in biological measurements. So, medical measurements exist in a continuum of this uncertainty. And we just talked about how much variation there is in DLCO. And a binary classification is probably artificial and maybe inappropriate in this context. So the greatest system is essentially organize everything to three zones: a zone of a high confidence of stability, a zone of high confidence of change, and then this uncertainty zone where contextualizing with clinical factors becomes even more important. And so that's where this greatest system is useful, and that's based on percentiles. And like I said, I kind of tried to analyze all different metrics, because although we use absolute values within our institution, there may be situations where percent predicted is used by a group because they prefer to use that, or a vendor or whatever else, or relative change is used by a group is used much less commonly. But we essentially have provided thresholds for each of these metrics. So whatever metrics is used within your institution, you can kind of contextualize that in the context of what this daily biological variability would be.
Yes. And
the advantage of a graded system is that it just kind of acknowledges uncertainty. It kind of reduces some of the overinterpretation that is definitely a risk when we are interpreting PFTs. It helps you kind of maybe decide who needs more monitoring, or who needs to come back in 3 months instead of 6 months. And it probably gives clinicians, a better way to discuss results with patients. And, even in the research context, potentially, you can define progression with a little bit more granularity as definite change versus, possible change. And it also allows you to have flexibility. There's times when you want sensitivity, there's times when you want specificity, and it has those factors. I mean, there is a downside too. I think it's more cognitive demanding to remember, multiple cutoffs than one. We try to round them up to things that are easy to remember. So for absolute, for example, the cutoffs are 3 for, below 3 stable, 3 to 4.5 is that zone of uncertainty, and greater than 4.5 is considered a definite change.
That's right.
And then the other part of it is that the binary or hybrid system. And so the hybrid approach essentially tries to account for the fact that, absolute thresholds depend on the baseline DLCO. And I think that there's a lot of situations where that's advantageous, and especially in those where you're really trying to monitor patients who have low DLCO, or you're looking after patients who are at the extremes of age where expected DLCO is going to be lower. And so I think that the graded system is easy for routine clinical monitoring and where you want to kind of acknowledge that uncertainty. But the hybrid system is something where, you want to try and minimize both demographic bias and the fact that you have a lot of patients who may have a very low DLCO. But the downside of the hybrid system is that I think it is more complex to use. There's a lot more kind of nuance to being able to interpret this easily and numbers to remember. So you have to kind of accept that complexity for improved performance across the range of DLCO. And essentially, no single threshold is optimal, but there's different systems outlined in this paper that can hopefully provide context for individuals based on what they're looking for.
Yeah. When I was reading the full paper, what I was thinking was like, yes, a little bit more uncertainty, perhaps a little bit more data points to remember, and more chances of individualizing the test results for the patient in front of me. Is that fair?
Exactly. And I think there's situations, like I said, where you want specificity, and there's situations where you want sensitivity, and understanding what is natural variability in this context can essentially allow you to define that. It's a hard thing to implement in practice because anytime you try and do this in practice, there's a lot of numbers to remember, a lot of different systems to remember.
Yeah.
Do you go off percent predicted? Do you go off absolute? Which one is best? And I think that that probably in order for this to be usable, it would have to have some kind of vendor integration that allows some of these numbers to be easily calculated on the PFT report, just so you don't have to sit there and try and calculate them yourself. And vendors typically are pretty responsive to individual institutions. So if there is something where you want to try and change the way something's reported, so you can kind of look at these more easily, I think it is doable. It just probably requires a little bit of kind of IT and logistics kind of legwork.
Yeah. So far, I can only think that is very worthwhile. So
yeah, go ahead.
No, tell me.
No, I was just saying. Yeah, I think acknowledging the uncertainty and knowing what true variability is was really the goal of trying to do this.
Yeah. But you know me, I love a good uncertainty, and I think again the trade-off of making this DLCO even more individualized is a fabulous equation in my brain, at least. So tell me, is there anything that you are going to change in your practice based on what you found?
Yeah, so essentially, as I mentioned to you right before we started here, this is all very new. We haven't even presented it within our kind of PF lab yet. So I think there's obviously co-authors here who are all part of our pulmonary function kind of lab and group here. But I think like most things for implementation, you need to have a working group of people who are engaged. So the PF lab plus also who are the people who are most likely to use this. It's going to be outpatient pulmonologists, especially those looking after ILD, COPD, maybe clinical trial coordinators. Those kind of people who are interested in knowing who really do monitor patients longitudinally, and to know what metric is helpful for you, or what's the most useful one, and is that uncertainty better? Is that hybrid system better? What is for a stakeholder group, what is most important? And I think that's probably the first place to start for us. And then we have between the paper and the supplement, there's kind of different tables that really outline what the different sensitivities and specificities are at all different cutoffs. We can kind of choose what is clinically meaningful for the stakeholders involved.
Yeah, I love that. And if you had a way, and this is just my curiosity, how do you explain the difference between female and male? And again, for our listeners who have the paper in front of them, I'm talking about figure 3 continued. In your what do you think?
Yeah, I think that that links a little bit back into table 2 as well. Really, the patient factors that influence variability, and there's there potentially issues with alveolar capillary membrane properties that might be different between sexes. Maybe technical factors that are different. Larger tidal volumes may be more difficult to standardize, so males may have more variability at baseline. The differences that so again, larger lung volumes may create their own issues with heterogeneous gas exchange. So I think there's a few different hypotheses, but none of them are particularly easy to test or to look at. But those are a few thoughts that just come to mind offhand. I haven't thought about that before, though, but that's pretty interesting.
Well, I appreciate all the insight scoops, because I was thinking about this, and I was wondering also, even though we do have in table 1 like mean age and things like that, and again, the youngest person included was 53 years old, but I wonder also if like where women are in their hormonal age also makes a difference. I don't know. I was just
it does. And just to clarify, that's the interquartile range. So like there's definitely younger patients in the cohort. That's the lower
fair.
quartile. Yeah. So
That's fair. I love this. I so appreciate you giving us the inside scoop exclusive. I'm very excited about this work, and for our listeners, so they can keep an eye out for your work. What are the next steps in this topic for you and your team?
Yeah, I think that there are a few ideas that we wanted to do, and a part of that really relates to some of the limitations that we have here. I mean, this is by no means kind of a perfect study. One interesting question is really the question of hemoglobin adjustment. We assume that we're doing it correctly, but is there a way to make that kind of better? And then the other issues for this kind of study is that this is very much a real world study. So there are less than idealized research conditions, and so trying to reproduce this in more controlled settings. Our demographics really reflect the catchment area that we're in, and so diversity here is relatively low. So 93% Caucasian population for the study. So I think doing this in a more heterogeneous cohort would be helpful. I really like to look at this in the context of more complete diagnostic information. So this is really a database-driven study. So what clinical diagnosis do these patients have, and how does DLCO variability change in that context? And then maybe find somebody who's more of a math nerd to find out, if we're going to do arbitrary kind of cutoff points for hybrid rules, is 50% predicted good? Is a z-score of negative 2.5 good? What are the better options there? So those are a few different kind of follow-on thoughts that I had for what to do next with this.
I love that, and you're going to have to come back once they are published.
That'll be awesome. I'd love to.
And before we end this episode, send a couple of clinical pearls based on your findings to our listeners for them to use on their day-to-day basis, on their day-to-day.
Yeah, I think that the two biggest ones are really related to the idea of biologic uncertainty. And one is that, anything that is near or at the lower limit of normal, is something that probably deserves its own level of scrutiny, because those are the patients that it's easy to miss kind of either change or a diagnosis. FEV1 FBC ratio is just above the lower limit of normal. Doesn't mean they don't have obstruction. It just might be really early. And then really kind of embracing the fact that, there are contexts where a test is imperfect. And so the overall kind of symptomatology, what's changed with radiology, what's changed with some other tests like 6-minute walk or whatever else, those really come into focus. So I think those are probably the two things I take away from that.
I love that. Thank you so much for sharing your time with me for the Chest Journal podcast. I really appreciate you. And I am super excited to see what's next for you. And I absolutely loved this paper. And I'm very thankful that you said yes to talk to me today.
No, thank you so much for having me on.
And I'm very excited that I get to say that I heard it firsthand, and so did our listeners. So thank you so much for listening to the Chest Journal podcast. Again, I'm Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota. And today I talked to my dear, dear friend, Dr. Hemang Yadav, about his work on the intercession variability in single breath diffusing capacity of carbon monoxide. Thank you so much for listening.